Hello, I'm John Molina. I'm Pasco Yaqui, San Carlos Apache, and I just greeted you in my Yaqui language. And I just want to say how happy I am to be here and hear about some of our colleagues here in Phoenix, and also to welcome you to this presentation for this afternoon or this morning. I am a retired OBGYN physician. I worked with the Indian Health Service for quite a few years here at Phoenix Indian Medical Center, and also I worked in urban Indian clinics as a health service administrator. And I guess I would say my experience spans about 30 years working both with the IHS. Spent 3 years up in Alaska, worked with Alaska Natives at the urban Indian clinic up there, and then also came back to Native Health, where I was a compliance officer and also a health service administrator. Just to let you know, I'm also on the board of directors for the San Carlos Apache Healthcare Corporation. I've been with them for 10 years. So just to say that it's just been an honor and a pleasure to work with our Indian communities, people from all nations. As you know, of course, here in Arizona, we have 22 federally recognized tribes, but because Phoenix is such a busy hub of people, we have natives that are relatives that come from all over the country to live, work, and go to school here in the Phoenix area. I heard that over 300 different tribes are represented here in the Phoenix area. So it's nice to say hi to all the relatives and thank you all for being here this morning. We'll pass on to the next slide. Of course, the topic is uterine cancer in Native Americans. I suspect everybody can hear me okay.
Dr. Molina, it actually is hard. It is a little hard to hear for those of us that are watching virtually. So if you could try to project a little bit more, that'd be great.
Okay. I suspect the speaker. Okay, so I guess if you can't hear me, just kind of flag me somewhere and I'll try to speak up a little bit more.
It's better when you speak up. That's great. Thank you.
Okay, good. I'll just kind of move up here. Okay. Right here. Just a little bit over here. Oh, there we go. Okay, we'll try this again. So again, just let me know. You can put it in the chat if you want to speak up a little bit or get a little bit closer. But okay, so today's presentation, we're going to be talking about uterine cancer in the population of Native Americans. Again, as a profession, as an OBGYN, took care of a lot of people related to uterine disorders, uterine cancers, and I hope I can share some of my experience and some of the work that I've done in that area. And again, just to say, these types of presentations are really, for me, very important because they help to educate our people a little bit on some of the areas that reflect, the impact of cancer. And in this way, we get a little bit more knowledge. Knowledge is good, it helps us to understand things better, but also knowledge that we can share with other people that you work with or even with our family. So just to give an overview of where we're going to go with this afternoon is, first of all, we're going to talk about a little bit about the anatomy of the uterus. And then we're going to be sharing a little bit about what uterine cancer is. We'll look at the risk factors behind uterine cancer. We'll also explore a little bit about the symptoms and what can pretty much expect with uterine cancer. And then we'll focus a little bit on how it's diagnosed, and then focus a little bit on what the treatments could be. And then we'll spend a little bit of time on the impact of uterine cancer among Native American people. And then we'll kind of finish up a little bit with how uterine cancer can be prevented. Then we'll give a little bit of time for questions or thoughts, comments, or stories that people might have. So I'll make sure to keep track of time so we can have at least a little bit of an open dialogue and share maybe some stories or maybe discuss some of the questions that people might have. So with that, let's kind of go to the first slide where we look at the anatomy of the uterus. Now, in medical terms, the uterus is described as in medicine we talk about the endometrium, the myometrium, or the perimetrium. And the very center of this picture That's where the uterus proper is right there. And it's interesting because I learned that, you know, a lot of medical terms come from Old Latin or Greek terms. And in this case, when we talk about like the endometrium, the myometrium, the perimetrium, which makes up the inner, the muscle, and the outer section of the uterus, they refer to it as metrium. Well, it's interesting that metrium comes from an Old Latin word, which means mother. It means mother. And I found that to be interesting because even back then, you know, medicine was a lot, not only medical care or medicines or science, but it was also philosophy. And I think a lot of people way back when kind of perceived the uterus as being, this is where we come from. And I think among our native people, it's very significant because this organ that the Creator has created, you know, for women is where life begins. This is where the life of our next generation comes from. And among our Indian people, it has a lot of significance and the importance of what it is and the care we want to give to the uterus. I also put there other parts of the uterus, of course, the fallopian tube, the infundibulum, the fibria, the ovary, and this is where the eggs come from the mom that go up into every cycle that you have each month. That's where the eggs come in from the ovary, travel up the fibria down to the fallopian tube, enter to the cavity of the uterus, and then if there's male sperm there, and then that's where it gets fertilized somewhere along that journey of the egg. But this is just to show you and get an impression of what the uterus looks like, so that when we talk about uterine cancer, we'll have a better idea on how we can be able to visualize this in terms of the work that we're talking about cancer. So what is uterine cancer? Well, it's a disease of cancer cells, malignant cells, that form in the tissue of the uterus, or also called the womb. Now, these cancer cells, if you can see it in this photo, it's shown there on sort of the right-hand side of the uterus. You can see where it says cancer. Well, the cancer can most commonly develops in the inside of the lining of the uterus, and that's called endometrial cancer. Now, the endometrium is really that part of the inside of the cell that during a woman's cycle sort of grows. It kind of prepares itself for the egg to come in and get planted on the endometrium. And when it plants there, it begins to grow, the endometrium. So that's where the fertilized egg comes in and plants on the inside of the lining, and then the inside of the lining begins to grow. It becomes thick with a lot of glandular cells, tissue. So, and then if the egg is not fertilized, so there's no fertilization of the egg, at the end of that cycle, that's when the woman will have her menstrual cycle, her period. So what was developed inside the uterus then falls out of the uterus during the menstrual cycle if the egg was not fertilized. Now, so cancer can develop most commonly on the lining of the uterus, the inside of the uterus, and that's the most common one. But also, it can also develop in the actual muscle of the uterus, what they call the myometrium. Myo means muscle. So the muscle of the uterus also can be an area for the cancer to develop in the uterus. When it develops in the muscle of the uterus, it's called a sarcoma. And that one tends to be a little bit more aggressive, in terms of how it proceeds and the kind of treatment that's needed. So let's move on to the next slide. Now, what are the risk factors for endometrial cancer? Again, this is the most common form of cancer. Well, first of all, is obesity is a leading risk factor because the excess fat tissue that one can carry increases estrogen level. Now, estrogen is responsible for producing the lining of the inside of the uterus. So in other words, during a woman's cycle, estrogen levels in your body start growing, start elevating, and this estrogen begins to develop this endometrial tissue in preparation for the egg to come in and be implanted in the uterus. But also, what also increases estrogen level is our fat. that can increase estrogen levels in a person and cause that tissue to grow, even though you're not in your cycle. The other thing that can cause the inside of the uterus to grow tissue is estrogen therapy or hormone therapy. Again, the key hormone that increases the lining of the uterus is estrogen. So estrogen can come from fat cells, or estrogen can come from hormone therapy. Now, you might know maybe some women, or you've experienced that after a woman enters menopause, in other words, she's not having cycles anymore. A lot of times, because some of the symptoms that women have in menopause, like hot flashes, and they have sweating, they have anxiety, all these sort of things that women talk about in menopause, sometimes the provider would put them on estrogen therapy. Because estrogen is a very good hormone for women, because that's what kind of keeps their temperature changes normal, their emotional balance. So estrogen is really an important hormone that the women carry. But when they reach menopause, the estrogen levels drop really low. So that's when the doctor might then recommend, well, let's put you on some estrogen so you can start feeling better. But one has to be careful, because if they take estrogen without progesterone, that's another hormone, because the progesterone helps to balance the estrogen, kind of balances it together. But if you're, as a woman has only taken hormone therapy, which is estrogen, she's in menopause, it could cause the risk of the endometrial cells growing inside the uterus. So that could also be kind of an issue. Okay, thank you, Gilberta. So as a woman, should a woman decline estrogen therapy? Well, it kind of depends. Typically what happens, every woman's experience during menopause is different. Some women can go totally fine during menopause. You know, they exercise, they watch, their diet, they do everything, and they go through menopause okay. The menopausal period can take anywhere from a year to 4 years. And then once it's gone, then everything's okay. It's just that period of time. But sometimes a woman just may be too uncomfortable during menopause. So they will go to the provider and say, gee, I'm having all these symptoms. What can I do? Well, the provider will more likely say, well, let's put you on estrogen. And it's up to the woman to decide if they want to try it, or maybe you want to try a trial of it. But typically, the doctor will not put you on just estrogen alone without the progesterone. In other words, they make combination pills now where it's both estrogen and progesterone. So in most cases, the doctor will say, well, let's try this. Let's go ahead and try hormone replacement therapy. But should always be careful that the estrogen is not given alone without progesterone. You should have that combination to balance it so you don't get too much estrogen, so the endometrial cells don't grow too much. So just to answer the question, it's really up to the patient, the person, if they want to take estrogen. I think it's a good idea to maybe try it, see how it feels. But again, once you're taking estrogen therapy after menopause, then you have to be very careful for abnormal bleeding, because you shouldn't have any bleeding after that. If you do, and you're on estrogen therapy, then obviously you have to go back to the doctor to see what's happening. The other thing that can cause endometrial cancer is starting menstruation before the age of 12. A lot of our young ladies now are starting their periods at 10, 11, 12 years old. So starting periods early then puts that individual on a lifetime cycle, a longer lifetime cycle that posterior estrogen. Because remember, when you have in your cycle, you produce estrogen to build up the endometrium so the egg can come and implant. So if a young lady is starting early on before 12, then she's already building estrogen in her body. It's going to last for a longer time. So they have a longer lifetime exposure to estrogen. Now, the other thing that happens that could potentially impact the risk for endometrial cancer is reproductive factors or issues. Never having been pregnant or experiencing infertility. Now, when a woman has children and she cycles, the fact that they've had children is a protective factor. In other words, because when you're pregnant, you have a child, your estrogen and progesterone work in balance to keep that pregnancy and eventually the baby's delivered. So, but a woman who's never had an infant, never had a baby, then she really has that time in her life, those 9 months, that she's constantly being exposed to more estrogen. But during those about 9 months of pregnancy, that's when everything's okay. You're not losing all that estrogen. So your life itself during pregnancy is really a protective factor also from your body producing too much estrogen, because those 9 months of that pregnancy really helps the woman be able to have that balance between estrogen and progesterone, because they don't have the period. They don't have periods during pregnancy. Now, the other one is medications. Tamoxifen has been known to potentially lead to endometrial cancer because it's kind of like an estrogen. But tamoxifen is used for breast cancer treatment. And I only bring it up here because when women are taking any types of medications for breast cancer, colon cancer, any other cancer, have to be careful that it's not a drug that is also like an estrogen. It causes the lining of the uterus to grow. The other one is what they call polycystic ovarian syndrome. In that photo that we showed in the beginning, you saw the 2 ovaries on the side. Well, those ovaries have little follicles where the eggs are at. And sometimes the polycystic ovarian syndrome is when those follicles become cysts, like little bitty cysts, and they grow. They can actually be about that big. And those polycystic ovaries can produce estrogen too. So the body's producing these kinds of estrogen, and it could come from the ovaries. So that's the other issue. Now, we're talking about all these risk factors that obviously is focused or directed towards women that still have their uterus. So a woman who's had a hysterectomy doesn't have to worry about this. So if a woman has had a hysterectomy, then obviously she's not going to have the risk for endometrial cancer because the uterus is taken out. And the uterus is usually taken out, and we'll talk about it a little bit, if they've had endometrial cancer. That's one of the treatments is to remove the uterus. Or other times that the uterus has been removed is that if they're young and they're having a lot of abnormal bleeding, or they have what they call fibroids, the little muscle tissue that grows in the uterus that causes it to bleed too much. It's not cancer. But if the woman's done having her children and she's like in her 30s and 40s, she might ask for a hysterectomy to stop bleeding from happening too much. So, so this one only deals with women who still have a uterus, but as a woman who's had a hysterectomy, removal of the uterus, then not to worry about this. So, okay, so let's go on to the next slide. Some more risk factors. Increases after the age of 40. In most cases occurring after menopause. So that's about the age that I've seen a lot of endometrial cancer cases. Is usually, especially in our Native women, usually late 30s and 40s and 50s. That's when we typically begin to see higher rates of endometrial cancer, again, for the reasons that we just talked about. Diabetes is also a risk factor for endometrial cancer. In fact, it doubles the risk of endometrial cancer. So if one is still in a reproductive age, in other words, you're still having cycles and you get pregnant, then, and you're diabetic, then it increases your risk by 2 times. In fact, I had a case here at Phoenix Indian Medical Center of a lady that came into the emergency room. She was having some irregular bleeding that made her anemic. And that's the other thing. If a woman is having too much bleeding from the uterus, they become anemic. And usually what happens, they do the blood work and they find out that she's using blood, becomes anemic. And this lady that came in, she also happened to be diabetic type 2, so taking insulin. And sure enough, you know, when we did the test for endometrial cancer, it turned out that she had along with that. So I guess when I think about this, it's good for women who are still in their reproductive age and they're diabetic and they have some of those risk factors. Maybe they might just want to make sure that they follow up with the doctor to make sure that any abnormal bleeding can be taken care of. Now, when I talk about abnormal bleeding, That means bleeding that takes place between cycles. You know, most women know when their cycles happen. But if you have bleeding between cycles, that's not usually normal. It's something that needs to be looked at. And that's one of the first things that I would say is that if there's any abnormal pattern or change in your menstrual cycle the way you know it, that's the time to get checked to make sure that you're not causing abnormal bleeding. Because again, like I say, hopefully not it's endometrial cancer or that or woman is not becoming anemic because of the abnormal bleeding. There's another thing that they call endometrial hyperplasia. This is a precancerous condition. Again, when we talk about the lining of the uterus that was growing, sometimes it grows really thick. It's not cancer, but because it's so thick, those cells, it could become cancer if it's not taken care of. A lot of times, women with endometrial hyperplasia come into the emergency room because they're heavy bleeding. And when we do a biopsy, it's not cancer, but it's just really overgrown cells. So, but there's treatment for that too. Then the other thing, of course, genetics is always involved here. They call this Lynch syndrome, which is a cancer that seems to come from cells that produce glands, like the colon, like the breast, like the endometrial tissue. These cells produce little glands, and that's what they're referring to there. But I've not ever seen that, hardly at all, or never actually. And then family personal history of ovarian, colon, or breast cancer could also be a risk factor for women who might be predisposed to endometrial cancer. So just to stop here a little bit and to say that again, you know, it's important, and I know it's very difficult to talk about this for a little bit, about the difficulty in women in reproductive ages or afterwards in trying to get, you know, themselves in sort of a routine to get an annual physical exams, because this is where a lot of this stuff can be talked about with the provider. You know, talk about reproductive history and the abnormal bleeding, things like that. It would be important to do. There's a question that says, I would love to, oh, sorry. We'll come back to that. I don't know if you can pull it up again, that question on the chat.
Let me see. But I know the askers could be addressing the questions at the end.
Okay,
Yeah.
let's just keep going on that one. I'll be happy to talk about, because birth control pills is a way to protect from endometrial cancer too, and we can talk about that. But birth control pills also have risk to it, but we'll talk about that. Okay, let's go to the next slide. Okay, so what are the symptoms for uterine cancer? We talked a little bit about this already. First of all, vaginal bleeding between periods or bleeding right before menopause. Typically what happens is there's a period of time they call perimenopause, which is getting close to menopause. And during this time, the woman might experience small bleeding or going 3 or 4 months without bleeding, then bleeding again, and then eventually all the bleeding stops. So, but anything that's vaginal bleeding between periods or before menopause, when you're still cycling, then that's something to get checked out. Vaginal bleeding or spotting after menopause, even a slight amount, that's something to get checked out. I did have a patient once, and she was already like in her late 60s or 70s. And what happens in older age with women, because of estrogen, that area where women pee, called the urethra, can get sort of, if you will, can get kind of very fragile. And sometimes when they pee, the women, it kind of burns a little bit. So what doctors will do is that they'll prescribe estrogen cream to put on the urethra, so it'll not make it as fragile. Now, and sometimes even vaginal creams like that in older women, that's estrogen, we cause them to bleed too. Again, it's the estrogen. If they have a uterus, that may cause them to bleed again, because it's affecting those endometrial cells again. It's kind of bringing them alive again with the estrogen. So even estrogen cream could be a cause of abnormal bleeding. Lower abdominal pain or cramping in your pelvis just below your belly. And when I say belly, just below the belly button in this area, because sometimes with endometrial cancer, the uterus can grow because the cells are starting to grow, right? Now, the uterus, unless you've been into anatomy, the normal size of the uterus is only about this big. That's the size of the uterus. But what happens is when the endometrial cells start growing, it can become bigger, almost the size of a big orange. When it's that size, women can feel that kind of a little bit of pain, kind of pressure, what they call it, giving some cramping. So that could be a sign that maybe something's going on here. It's not. You may not have the bleeding yet, but the uterus is starting to grow, and you can feel it here down here. The other thing is having any kind of a discharge. If a woman is postmenopausal, in other words, she's hit her menopause, and the average age of menopause is usually around the early 50s, 51, 52. That's when they hit menopause, and all the bleeding has stopped. But if they have any kind of a discharge, or vaginal discharge, white or clear, then that's something to be looking for. Then the other thing is extreme prolonged heavy bleeding or frequent vaginal bleeding if you're older than 40. So again, the bottom line of this slide is anything that's abnormal to what the woman's body normally experiences. In other words, you're saying, this doesn't feel right. That's a time to get on it, because the earlier it's caught, the better the treatment's outcomes can be. Okay, let's hit the next slide. Okay, diagnosis of uterine cancer. Now, these diagnosis is important because I think that the initial diagnosis doesn't really is not as invasive. It is a little invasive, but not as much. It could be. For instance, that patient I talked about that came into the emergency room that was bleeding type 2 diabetes, the way we found out she had uterine cancer is by a endometrial biopsy. And that's usually done, it can actually be done in the emergency department. It's done with a kind of a long, what they call a pipette. It's about that long. And it's really thin. It's much thinner than a straw, actually. And what we do is we put that into the cervix. When you saw the diagram, goes into the cervix, and then we pull out a plunger, and it sucks up some of the cells that are inside the uterus. Then those cells are captured in the new tube. It's taken to pathology, and they can pretty much give you kind of an answer. Now, if it comes back positive, well, then we know we're dealing with endometrial cancer. If it comes back negative, then we're not still quite sure, because those cells that are inside the uterus, wherever the tube got the cells, maybe it missed it. Maybe it got cells that were not cancer, but there's still cancer cells there, right? So if it's positive, we know it's cancer. If it's not positive, then we kind of scratch our head and go, well, maybe we missed the area. So then what we got to do is then maybe still try to figure it out. Then we do what we call a DNC, and I think most women know what a DNC is. That's usually done in the operating room. We have to put the woman under sedation, because then we have to go into the cervix with a curette. There's a tool that goes in and we scrape the inside of the uterus to try to get all the cells out. So now we can see what's in there. So that's scraping the tissue from the uterus. And that's if the biopsies are unclear or insufficient. So that's the step we have to do there. The other thing that might be done in the emergency department is a transvaginal ultrasound, kind of like an ultrasound that we do when a woman's pregnant. And we usually go into the vagina to see the image of the uterus, because we can be able to see the uterus through the ultrasound, but what we're looking for is the inside of the ultrasound. And the inside of the ultrasound of the uterus by ultrasound can show there's a lot of tissue in there. It's growing too much. There's too much tissue in there that we can see by ultrasound. So that really helps us to detect if not only anything going on inside the uterus, But if there's anything tumors growing in the muscle of the uterus, see, that's the other thing. The other thing that could be causing abdominal bleeding, which I haven't brought up yet, is any tumors, any what they call fibroids. Fibroid tumors are not cancer, but they're little pockets of muscle tissue that grow out of the uterus that can cause bleeding, but it's not cancerous. So that's another thing that could cause bleeding in the uterus. Then we can do a hysteroscopy. That's again done in the operating room, where we actually go in with a camera to the cervix, and we can actually see the inside of the uterus. We can go in with a scope and see all the inside of the uterus to see how normal or abnormal it looks. And then that way we can look for any area we can biopsy with that. And then finally, you know, they do imaging lab tests. It depends on the facility, the provider. They can use CT, MRIs, PET scans, even a blood test for cancer, which is called a CA-125, to see if your blood shows you might have cancer. Now, these tests are usually done to see if the cancer has spread outside the uterus. In other words, it started in the uterus, but then it begins to spread out. It can spread out into the tube, it can spread out to the side of the pelvis, it can spread out into tissue, it can spread out into the lymph nodes, and unfortunately, in the worst case scenarios, it can spread into the lungs. So they usually do these other tests to make sure that they don't see any areas of the body where the tumor could have spread or the cancer could have spread. Okay. Next slide. Okay, treatment for uterine cancer. Well, it all depends, as it says here, on the size, the location, and how far the cancer has spread. Now, most cases, if it's captured early enough, like in other words, the woman starts having irregular bleeding, doesn't feel right, they feel something in their abdomen, they've been feeling like that for the last few weeks or last year. If they go in within that period of time, pretty much we can catch it, we can treat it. Because it's just in the uterus, it hasn't spread outside the uterus, so it's inside the uterus. And in most cases, if that's all it is in the uterus, then the treatment for it would be surgery. You just remove the uterus. In most cases, they might remove the uterus and the fallopian tubes and the ovaries at the same time. But it kind of depends on where on how far the cancer is. It depends on the doctor. What else here? Okay, so that's one thing. Now, when it's done in that fashion, if it's caught early, it's in the uterus, it hasn't spread, they take out the uterus. In those cases, survival rates are pretty much about 96%, up to 100%. They're taken care of. Now, when they talk about 5-year survival rates, the way cancer people talk about 5-year survival rates, is that if you've been treated for cancer, and then 5 years later, you still don't have any cancer, you pretty much say you're cured. So when you see that 5-year survival rate, that's what it means. If you've made it to 5 years, then it's pretty much gone. So if it's localized just to the uterus, surgery is done, it's taken out, then everything's okay. Now, if it's regional, in other words, it's spread out of the uterus, it's gotten into maybe the lymph nodes, and it's gotten maybe into the fallopian tube, a little bit of what they call the parametrium around there, then it might need more surgery, but also chemotherapy, because now it's spread a little bit further. It's just not a uterus. So they do chemotherapy, or they might do radiation. That's the other way to do it. Or they might do targeted therapy. Now, in today's medical field, they have a lot of sort of cancer drugs that they can use that target the specific cancers. They're made in the laboratory, and they're focused on targeting cancer cells. So now they've developed a lot of different types of medications to target the actual endometrial cancer cell itself. So that's what they use. But typically, chemotherapy and radiation are the most common to use if it's regional. And the 5-year survival rate, if it's regional, then it's about 72%. That's about as far as 5-year survival rates go. Now, if it's distant, In other words, those endometrial cells got into the lungs, and now we see cancer in the lungs. Well, even with all these therapies, the survival rate is about. And that's pretty much true with any cancer. Any cancer, whether it's colon, whether it's breast, whether it's pancreatic, any cancer, once it's into the lungs, then they'll try as much as they can, but the survival rates aren't that good. So the takeaway from this is pretty much to get the person to be seen as soon as things are not looking right. So in that way, it's a very high survival rate. It's a surgery that's pretty straightforward. Everything was fine, and the person okay. Okay, let's talk here a little bit. Okay, how about endometrial cancer and Native Americans? Well, among their women, they have the highest rate and early onset of endometrial cancer compared to other racial ethnic groups. Now, why would that be? Well, my experience has been is that the two biggest factors that I've seen with the women, the one is diabetes. The diabetes, again, that we saw, is a risk factor. It doubles the risk for endometrial cancer. Also, the other thing that could be done, maybe family history, anything related to estrogen intake would be the other thing. And also we talked about weight control. That's the other one because the weight, the extra fat produces estrogen. So I think those are the ones that really sort of impact our women too, to have the highest rates. Now, interesting in that first bullet, early onset. In other words, we see women, our Native women, with endometrial cancer as early as the early 30s. Again, because of the combination of risk factors. So again, as it says there, almost a quarter of endometrial cancer cases among American Indian women are early onset. Again, we talk about endometrial cancer overall across the country. They were talking in the 40s, right? But our women get it much earlier than that. So again, just have to be on the lookout. Again, the highest proportion being between 35 and 49 age group. Women in the northern plains, southern plains have the highest rate of uterine cancer compared to other regions. You know, when I look at that, again, I think a lot of it has to do with the environment, perhaps with the past. It's interesting to note how different Native people in different pockets of the country, and even Alaska, have differences in cancer rates. And I think a lot of it might be even due to the environment. There's something there that kind of contributes to that. Now, in Indian country, and I know a lot of you kind of have experiences, is access to care issues. So we talked about the anatomy of the uterus. We talked about cancer, how it comes up. We talked about risk factors. We talked about treatment. But the biggest issue that I see in Indian country is access to care. You know, where can they go for care? Especially in the rural areas. In the rural areas where you don't have all these sort of facilities that you would here, like clinics, you know. When you're up in the northern part of this state, or you're up in the plains area, or you're up in rural areas of Montana, getting access to the care is what has really complicated that other issue. Geography, we just talked about that. How close are they to a facility that they can't see a provider? Not only that, but how can they get there? Do they have a card? A lot of our women, you know, take care of their children, take care of their family, even to get the time to do something like this, to make the appointment, to go in. It's a lot of work, you know. So that has been one of the things that I think a lot of us, wherever you work at, you know, we can always kind of figure out ways on how we can improve access to care, especially based around geography, you know, kind of working in different facilities. I know now some of you heard about this big, beautiful bill, the Rural Health Transformation Program. And states will be given a lot of money to improve care to help rural health areas. So hoping your organization, you know, we're working with rural healthcare providers to try to improve care in rural areas. The other thing is specialty care. Now, we talk about endometrial cancer. I think that in the emergency room, the use of that little pipette to take a sample of the uterus is pretty straightforward. And I think, you know, family doctors or nurse practitioners can actually do that procedure right there to get that sample. It's not very difficult to do. But if something comes up, then they gotta be referred to like an OBGYN. Now you gotta get referred to specialty care. And that's where it becomes a little bit more difficult because some of our clinics in the outlying area don't have that specialty care. You know, now you gotta get transferred to the specialty care. Now you gotta get the approval from the Indian Health, IHS, or you gotta go to PRC, or it becomes a little bit, not only getting there, but administrative work to try to get somebody to get to the care is the other thing. Insurance status, again, that's a big thing. I think most of our people are covered by Medicaid. Some hospitals like PIMC, they do have OBGYN doctors there that can do this, but insurance status is another issue. And then discrimination, cultural barriers. I think some of our women, this kind of problem with our women, I know it's something that's very private to them. Talk a lot about it, so it's difficult for them to come out, and especially to go into the Western world where you're not as culturally sensitive to this. And I can give you an example. I'm keeping track of time, but we can answer some questions. This is an example that just kind of blew me away. I had a small clinic in my community of Guadalupe, and one of the women that came in to me, she came in for those symptoms. She was only in her 30s, having abnormal bleedings. So I did the endometrial biopsy, and she had endometrial cancer. Now, at the time, she did have insurance, and I thought, well, let's go ahead and send you to a friend of mine who's a GYN oncologist. Usually GYN oncologists are the people that take care of endometrial cancer, right? So I sent her to him. And then I figured, okay, she'll be taken care of, she'll be fine. And then she comes back to me. But she didn't come back to see me until like 9 months later. I kind of wonder what happened. She actually goes to the provider. A lot of times when one refers a provider out, you get a report back that said this patient came and this is what we found. But I didn't get any record, nothing. She comes back 9 months later. She's really in a good mood and she's happy. And I says, hey, what happened? I sent you to see this doctor to take surgery. Oh no, I left his office. So what happened? Well, I was talking with this doctor, he said, and I was telling my symptoms, and I told him, you know what she said? I'm very traditional, I'm very spiritual, and I know that the Great Spirit will take care of me. She said that to the Anglo doctor. And she told me that the Anglo doctor's response was, I'm sorry, young lady, I'm the only one that can hear. That kind of conversation turns anybody. The Native people, the patient that I saw, I know we give that trust in Creator, take care of us. It's part of who we are. It's part of what we believe in ourselves. It's our traditions. It's our values. It's our health. And yet, to be treated this way in an office turned her away totally. She walked out of the office. I said, "What did you do? What happened?" Well, and this part is kind of interesting. I only share it with you because I still have issues to think about this. But she said, so I went to my traditional healer up north, and I went to him, and he told me to go up north to this special place to look for this white clay. I'm not white clay, red clay. She said, special clay to bring it back to him. And she went on to describe to me what he did with this clay for her. And he told her, you'll be cured in a week. And she said that after a week, she had this really heavy blood flow. Something just came out of her vagina. She said she was cured. Now she comes back to me happy. She says, I'm cured, Dr. Molina. Everything's fine. Okay, well, let me just make sure. So what I did was I did an ultrasound, didn't see anything in the uterus. I did an endometrial biopsy. I just share that with you because, I think our people for many centuries have had ways of taking care of themselves. one of the issues when I look at discrimination and cultural barriers is that the Western world doesn't see it the same way we do. I think the most important thing we can do to educate our other providers is who we are as people. What we believe. And all we're asking for is with respect. You don't have to believe in it, but just say, okay. That's the point I bring here. That goes back to access to care issues. I think sometimes people don't want to go to this Western care. So that's the other thing I just want to bring up to start. Anyway, last slide, I think, before we get in there. Okay, it's preventing uterine cancer. Again, we talked a little bit about this. Having a healthy weight increases risk 3 times for uterine cancer. Be active, lowers the risk of blood pressure and diabetes. Discuss risk and benefits of hormone therapy with your provider. Use of hormones can increase your risk of uterine cancer, like estrogen therapy. And the last bullet is probably the most important. See your provider for any abnormal vaginal, anything that you know that, hey, this is not right. You know, it might not be endometrial cancer, it could be fibroids, could be an infection, anything else, but certainly want to take a look at it to get proper treatment. So this way, once you get the treatment, it really lowers your risk of uterine cancer. And that's the other thing about uterine cancer. It develops over a period of years. When I asked a woman, that lady that had endometrial cancer, I said, how long has this been going on? Oh, about 6 years. 6 years. You know, so you want to get seen early enough to where you can get treated and you can make that almost 100% cure. Next slide. Okay, well, this is my last one. Chokwe, which is Yaki. Thank you. This is a quote from Oaxaca Lakota leaders, chief citizens. Let us put our minds together to see what can we do for our children. Again, going back to the picture of the uterus, the uterine, what was in Latin called the mother body. That's our next generation. We want to take care of it. We want to see it as sacred. We want to protect it. That little girl is our granddaughter. She's my wife is Oglala Lakota, my language. Of course, she's all dressed up for the Gathering of Nations in Albuquerque. So, anyway, with that, I want to thank you, everybody, for being here. And I think we're open up for questions. We got a good time here to answer any questions people might have.
Yeah, how much is hereditary play into it?
Basically, hereditary genetics across the board, it's only about 15%. You know, and that's an interesting question because there's a lot of focus on genetics, and there's certain genetic things that do come out of colon cancer, breast cancer, pancreatic cancer, but really ultimately it's only about 15-20%.
The mother had it, that the daughter should be looking out for it.
Yeah, absolutely. And that's the other good thing is that if someone in your family had it, even though the genetic factor is small, it could still be part of the 50%. Yeah. Good question.
We have a
Dr.
question.
You have a couple questions in the chat. So one says, would you do an endometrial biopsy as a screening for a woman with a lot of risk factors, even if they are asymptomatic?
I said one more time.
Would you do an endometrial biopsy as a screening for a woman with a lot of risk factors, even if they are asymptomatic?
No, because one of the things you've got to balance. Now, the endometrial biopsy is not that, it's a little invasive. So you've got to balance the invasive factors with what you're looking at. In most cases, in my thinking, it might be different with providers. But if there's a showing of abnormal bleeding, because again, what happens, the endometrium builds up those plant tissues and it bleeds out. That's what's going on with the issue. And if it's not bleeding out, if you do an endometrial biopsy without any symptoms or risk, even though there's risk factors, I think the calling point is that they're having symptoms. Even though the risk factors are there, they might be heavy, maybe estrogen therapy, maybe they're diabetic. But if there's no abnormal bleeding, I probably wouldn't do the endometrial biopsy only because there's probably nothing that's going to come back. It's a showing of the abnormal bleeding that I think will tell the story.
Thank you. Another question in here is, so as a woman, should a woman decline estrogen therapy?
Again, that's a personal decision. I think that's kind of between the patient and the provider to look at the history and look at her lifestyle. If this is something, if she's really having bad, perimenopausal or menopausal symptoms, hormone therapy could help. It also helps with depression, anxiety, the night sweats, sleeplessness. And I've seen women being able to enjoy the estrogen replacement therapy because it helps them. But again, if you're taking estrogen replacement therapy, you need to take progesterone also. Now, if that also needs to be followed. So if you're on estrogen replacement therapy, you need to just continue to see the provider to make sure that there's nothing abnormal going on with it. And to ensure that the therapy is taking care of your treatments that you have, the symptoms that you're having, the hot flushes, the sleeplessness, the depression, that it's actually working.
And a question that just came in is, do you recommend weight loss and exercise for prevention? If so, are you aware of any successful programs to reduce these risk factors? Thanks for this great presentation.
Yeah, that's a good question. Again, it all depends. It depends where you live, the resources that you have, but overall, I've always believed that good health comes by eating right, being active. Again, I don't say too much like exercising a lot, like going to the gym, but just being active. Being outside, being active, moving, a healthy diet. These are all good sort of lifestyle habits to take in to reduce blood pressure, reduce risk of diabetes, or to manage your diabetes if you have diabetes. So all these things are protective factors that I think are important. For me, again, it's just moving, being active. Today's world, there's so many things you can shop online. You got DoorDash, you got everything. But taking a trip out to the supermarket or the store, parking a little bit away so you can walk a little bit. Not in this hot weather, but being able to just be active and move. That's the most important part of it. And then having a well-balanced life. But whatever your family environment might be, to make sure you don't get too stressful, too anxious, too depressed. That's always important. I think within our people, family is important. And the ability to all have good, healthy relationships is also important.
And one individual has a question online. Joan Walker, you can state your question.
Hi, it's not really a question. I have been trying to become more involved with the Native American populations in Oklahoma, but nationwide it would be even better. I have developed 3 protocols for prevention of cancer. One is ovarian, one's endometrial, and one's cervix. For our endometrial cancer protocol, we believe in a Molina IUD. So the intrauterine device that provides contraception for women also provides progestin therapy to the uterus. And so I am trying to convince populations to consider counteracting the obesity epidemic that we have. And overall in the nation, 3% of women get endometrial cancer, and that's just the average woman. But then when you have a BMI of 40, your risk is 10%. And so I do appreciate that an IUD is uncomfortable to place, but I have a protocol that I'm opening in OU Health in Oklahoma City, where we give everybody what's called a progesterone challenge test and give them Provera for 10 days. And if they have a menstrual period following that, that means they have too much estrogen, and then asking them to undergo an endometrial biopsy and intrauterine Mirena IUD placement so that they can be prevented from getting endometrial cancer. And so I'm trying to not sit back and wait for people to have stage 3 cancer like we are getting in our clinic, but to prevent it. And we also need an education about the menstrual cycle and what's abnormal, and not have people come in 5 years after their menopause should have happened and still be bleeding. So anyway, I'd love to find out who I could work with to try to implement a protocol within the Native American population to try to prevent endometrial cancer, because obesity exists. We do have GLP-1s, we do have weight loss clinics, but we have to just kind of take people for where they are. And if they can't reduce their weight, then maybe place an IUD and prevent the cancer.
I guess we can connect offline now. To Trudy, and then we can follow up with.
Yes.
Yeah. We'll go ahead and follow up on them. Thank you so much. You know, that kind of made me think about the other question about should you do an endometrial biopsy just based on risk factors? And I said, well, not really. I mean, you're waiting for the abnormal bleeding to start, right?
The ultrasound too.
Oh, the ultrasound, yeah.
Yeah, that's what my doctor. So I'm an endometrial.
Okay, yeah, that's the other thing you could do. You could do an ultrasound to see if there's any growth of the tissue in it. And what she mentioned was also another way to do it. It's called the progesterone challenge, where you actually give that pill called Provera for 10 days. You stop it. And then if there's any growth of tissue in there, even arthritis, it will come out. So that's another way to even get ahead of the game to see if there's anything going on, even for the bleeding side. The ultrasound. Yeah.
Yeah.
So yeah, that's another way to do it. Yeah. Good call.
Are there any additional questions in the room right now?
I'm in a lawsuit with Dr. Rivera, so I don't know if you know what's going on with it. So, yeah, my oldest son is 34. That's when I had started it. And that's when the warning label came out for it. So I suffered a lot. But then I had surgery. But like I said, it's in
Would you repeat the question for those of us online?
So someone was just sharing about their experience with the Depo-Vera, the birth control shots, and the side effects that they experience.
Yeah.
So Dr. Molina is just going to make some comments.
Yeah, I was just going to say that Depo-Provera is a progesterone, and when you administer Depo-Provera, it keeps the woman from being pregnant, but it also usually stops periods. And women have experienced anything from headaches to weight gain, a lot of different issues. And I think after long-term use, that's when you find out that there's other things that can create. And I think this is what happened in her case. That a lot of times when a new drug comes out, even if it's been approved by the FDA, you don't know the really long-term effects. It might come out a lot later. And that's unfortunate, you know. But then Depo was very popular to prevent pregnancies, and also it kind of works against estrogen to prevent the growth of these endometrial cells. But again, like unfortunately, you know, there were some side effects that were not known.
a lot because I'm over 50 years old. I don't even know when I went to menopause because we had to take out literally 20 tubes of blood and yeah, to show that I was in early menopause at some point. Just because the Depo-Provera for me, I didn't have no periods. And then when I did stop it, I had it really heavy, and they had to actually put me back on because it was a lot. It was a lot. That's a lot of different side effects for me. I'm not speaking for everyone, but just what happened.
Well, you bring up a good point too, because I think many times, well, you know, in today's age, in today's access to a lot of online information, it's good to, as much as you can, learn about your condition, treatments, what's available, so that when you go into the provider, the person can have a little bit more understanding and ask some of these questions. You know, many times, you know, providers are in a rush, they're in a hurry, but take time to ask the questions, to learn more about it. And then after a while, you know, follow up with treatment every year to see if there's anything that's changed.
Everyone says great presentation. They've really enjoyed it. And there's no more questions online and there's no more questions in the room at the time. So we just ask that those online, we put up the survey, a short survey for you to provide feedback and to complete it. And we have one more question behind it, Dr. Molina.
It's more of a comment than anything. Oh, in my lived experience, one of the disparities regarding uterine cancer is two things. Number one is a normalization of symptoms. A lot of Indigenous women will just normalize it, and it's almost like you're lying to yourself. Oh, that's just who I am. Oh, that's just the way it is. My auntie was the same way. This, that. There's these excuses and the normalization of symptoms that are very major symptoms, and then it's way later that you find out, oh, all along that wasn't normal. And I always hear that from the ladies. The second fold would be like embarrassment or public shame being seen at the OBGYN because of the connotation of pregnancy. And it's what I call public scrutiny. So it's like, oh, well, I saw her at the lady's office. Well, you know what that means. 10 months from now, let's see what happens. And no, it's the cancer. No, it's symptoms. And because the women don't want to be associated or put through that public scrutiny of being associated with pregnancy or menopause or what have you, so they choose not to even go in at all. And that's why so many women are caught in the ER, because that's socially acceptable. Oh, well, she went to the ER, she wasn't feeling good. Oh, and it all turns out it's cancer. But if the same woman who was, barely symptomatic or in hyperplasia went to the OBGYN, well, we saw her at the ladies' doctor, she probably has something. Who knows? You lay down with dogs, get fleas. There's no baby, so she got something, like that public scrutiny. And all along it was a cancer or hyperplasia that was getting treated. In my personal experience, when it comes to Indigenous communities and what we see with Indigenous women and the uterine cancer, it's always a normalization of public scrutiny and what I call saving face. Because Indigenous people are a saving face collective in society, set on saving face. And you see the ramifications of disparity in our cancer rates and the way public scrutinize women over their everyday decisions.
That's some amazing insights, and that's so totally true. See that, from our communities, and you're right, I've seen that a lot. That's why, again, getting a good understanding of these sort of issues is very important.
Well, thank you all. Thank you to everyone that's online. I can't have law on school to everyone that joined us today. Let's give Dr. Molina a round of applause for a great presentation. And then don't forget to fill out the evaluation that is shared, because your feedback is very important. And then our next Indigenous Health topic will be April, where's the slide at? I think it's April 16th. No, April 17th, that's on a Friday. It's usually on the third Friday of every month. And we'll have, the title is called Films in Indigenous Cancer Health, Engaging Two-Spirit and Indigenous LGBT Communities by Josie Rafaelito, the Assistant Director, Department of Indigenous Cancer Health from Roswell Park Comprehensive Cancer Center. So with that, thank you very much. And make sure, just like I said earlier, today is the National Native HIV/AIDS Awareness Day. And please share that with your community and get tested and know your HIV status. Yeah, thank you.
Thank you, everybody.